inflammation of
endocardium of the heart. That usually affects the cardiac
Is
valve.
it this side or
That side.
this side?
Oh, I
Ah,
was reading the wrong
there it is. All right. Yes, but you're correct. Infection of the inner layer of the heart that usually affects the cardiac valves. Okay. Infective. Everybody knows infective means endocarditis. Endo. Side. Carditis. Heart. Yes, ma'am.
Is this bacterial? Or
No,
is this
we're-
like literally like? Because it's an infection, would it be like a bacterial infection?
It could be bacterial. It can be viral. It can be fungal.
Anything.
Yep.
Okay.
It depends how they got it. But we'll get there. It is not the funnest thing ever to have. It was always fatal until someone decided to start growing some mold. And then
What?
one
Please
mold.
don't tell me people get
Penicillin.
Oh,
Penicillin is mold. Oh my goodness.
It's
I really don't know that much. I'm sorry.
Yes, penicillin has nothing to do with this class or the task, but penicillin was discovered after, I don't remember who the scientist was, no he was saving me, but grew mold.
Yeah, no one's giving
So,
me mold.
If you've taken an antibiotic, you have eaten mold.
I'm so. Okay, go ahead. Keep on going.
You're all right. It's purified. It is not. Like
I'm
we're gonna-
sure it is.
It is. It's fine. It's all right. Okay. Classifications. So subacute is a pre-existing pre-existing valve disease. What would be a pre-existing valve disease?
mitral valve prolapse.
There you go. Mitral valve. Anything. Also, if they are born with maybe a defective valve. Okay. Longer clinical course, which means they're going to be in the hospital a long time, and caused by endococci. Okay, that's typically what is going to cause it because it's going to aim at the cardiac muscles. That's who is it's attracted to. Okay. Acute form, you're going to see in patients with healthy valves, absolutely no cardiac history whatsoever. Much shorter course, easier to take care of, easier to treat, but it is a rapid onset, so the person's going to get a lot sicker a lot faster. Anybody know one of the direct correlations why endocarditis comes on? What other body system it typically originates in?
Yeah. The mouth.
Specifically gingivitis. Gets infected,
That makes sense.
those cardiac veins go right to the heart. So if you have a patient, and I've had this with several cardiovascular surgeons that had to do open heart surgery, they had a orthodontist professional come in to either extract teeth that needed to go or clean the teeth to make sure the teeth were healthy.
My dad's friend died recently from like a tooth infection.
Mm-hmm. Because all of these little vessels and nerves, these are connected to your cardiovascular system. So they're a direct link.
So most common is from gingivitis.
Yes,
Okay.
that's where it starts. That's why a lot of people like, I know some people are like, hey, going to the dentist. I get that, right? It's not the funnest thing in the world. But it's very important because I've had people that I've had to do surgery on to go take vegetation. I do mean vegetation, scrape it from their interior part of their heart because their teeth were so bad, and the infection started here and it went down there. This gentleman lost all of his limbs, and then eventually died
Oh my God.
because of it. It can be very serious. Okay. Pathology of this. So, your risk factors, your biggest risk factors are age and
Drug abuse.
that's getting a lot bigger right now.
Mm-hmm.
So it's
Okay.
heroin.
Heroin and cocaine injections. Because are those needles clean? Are they getting a clean needle from Walgreens or? No,
Use
they're
a
not.
sterile technique.
Yeah, I doubt they're using sterile. I doubt that's what's on their mind. I could be
You know what they're
completely
doing?
wrong, but
I don't know where they're doing this, I just saw it on the news, that they're opening a clinic with doctors and nurses where drug users can go use drugs in this clinic.
Is it the
That's
methadone
insane,
clinic?
that's absolutely insane.
well, methadone clinic's been doing that for a while.
But yes.
But
So
it's
this is
legal
very-
methadone. They're coming in to get the
Yeah.
methadone
No, this
shots to
is-
get off drugs.
A clinic where you go in there to use drugs.
Why are they doing this? This is true. It's happening all over the country.
So they don't
Because people are
overdose.
dying.
Hepatitis C.
You can prevent the person ODing and dying. You can prevent infection, and you can prevent the transmission of disease.
Oh, that pisses me off. That's
Yeah, I don't
So
like
that's
that.
legal,
That's-
Yeah,
marijuana
it's-
isn't legal.
Here's the thing. Did were any of you able to go to the community talk where the community nurse came in and talked about,
No, I wanted to.
yeah, the fentanyl talk?
Yeah, I was in there.
They're giving away Narcan. You can go to the community center and get Narcan for free. It's a nasal one and I can tell you how many people I've taken care of in the ERs that they'll all get together and they're gonna get high. It's just happening. So I'm not even gonna like skirt around the bush. People are out there getting high 24 hours a day. So what happens is you have a group of people, they're gonna go shoot up. One of them doesn't, so he or she can knock on the rest of the group.
So why even make it
Why make what?
Narcan?
Mistakes
People are gonna
happen.
die.
Here's the thing, eventually if someone doesn't stop, eventually an OD, a drug hit will kill them. Because
Okay.
cocaine and heroin both can build up in the system. And cocaine, what does it do to your aorta? Thins out and weakens it, so eventually, it's a statewide initiative. They are trying to decrease the death rate. But one of the issues we're seeing, especially in Kenosha and Racine, our drug use isn't bad in Kenosha, Racine. It's not bad. What's bad is people are traveling between the two big cities to get whatever they want to do, and they can't wait to get home, so they're literally pulling off at the Woodmans in Kenosha to shoot up, and they're ODing in their car, and someone's finding them. There is absolutely nothing we can do.
Really,
So-
really bad. Or my husband's from Kentucky. They're doing a documentary on it.
Oh,
It's
awful.
really bad in my town.
So we're seeing the effect of endocarditis on a rise because of this.
So sad.
The good part about it, if someone has this and we can get them into the hospital, they're going to be in the hospital long enough to detox. They are. They're going to be in the hospital 7 to 10 days with IV antibiotics because you can't get the infection controlled around the heart. Eventually, that infection will squeeze the heart and it'll stop. So
And then they'll have to have a sitter.
the what?
Costing more money. What?
Oh.
I'm sorry. I just really don't like this.
That's okay. Prosthetic valves. So a fake valve, yes. A pig valve. Yes, we use pig valves for heart disease. We do. Works great. Use of intravascular devices. This doesn't mean they're doing anything wrong. Maybe they've had a PICC line in, and maybe it was just in a little bit too long, or maybe the patient and family members didn't really take care of it as well as they could have, and an infection. I mean, all those central lines go right to the aorta. Every single one of them. Doesn't matter where it starts. They all go to the aorta. Then renal dialysis, for the same reason. If you're on renal dialysis, you have a fistula or a shunt. The same thing. Infection rate, it's going right to the aorta. Okay.
So could pacemakers also kind of fall under the vascular?
Pacemakers don't, because once they're in and they're enclosed and the site's healed, you're good. But with the central lines, there's always that out source. So, good question.
Okay, but above all this is still gingivitis.
Yeah.
Okay, just want to make sure.
As of the end of 2017, so yeah, it could change in the year. I mean, it could change by the end of the year. My entire slide might have to change. So here's the vegetation. This is what happens. The infection starts, and then the heart starts to grow stuff. Seriously, it's disgusting. It's really weird.
What
And
does it look like when it grows? Like,
I don't want to
I'm
tell you because
thinking
you
like
might never
moss or
want to eat a
something.
vegetable again.
So
Like
it
cauliflower.
actually looks
A green cauliflower.
really.
Mm-hmm.
Okay.
gross.
It is vegetation.
Okay.
So it's very hard to get rid of it too. Like we'll go in and try to scrape it through a calf, but you can only get so much out.
That probably smells so bad.
Yes, sir.
Signs and symptoms of that, or just typical of any other infection? Or?
Smelly breath.
Oh, next slide.
Good leeway.
Okay.
Good lead in. Okay, good. So yes, the signs and symptoms. What do we got?
Vegetation is what
Can you read it?
spots
if
on
you
the
don't
retina.
Okay.
Yes.
And what are those?
I don't want you guys falling asleep, but maybe for the slide. So lesions on the hands and the fingers. Because the heart's starting to shunt, so anything where the circulation's gonna get poor, you're gonna see that. So on the hands, on the feet, you're gonna start getting ulcers for no reason whatsoever.
Does that say splinter hemorrhages?
Mm-hmm. So what is a splinter?
Little stick.
A little thing,
Or thing, yeah.
whatever. We typically associate with wood, right? But a splinter can virtually be anything. And usually it kind of goes down to the fingers, like you see it. Same concept. You see like this red thing that looks like a splinter. Okay?
What is jaw? The one that's
Joint way lesions?
Joint lesions? Those are lesions on the palms and the tips of the fingers.
Oh,
And then you have the ulcer nodes, which are on the heels and the toes.
And what
Okay.
are Roth spots on the retina?
Red spots.
Just red.
Yeah, they're just called Roth for some
Fancy
reason.
word.
For people like to try to get fancy.
And that you're only going to be able to see if you do like.
Mhm. Yep. And you'll see it. It'll be very pronounced. You won't miss it. Typically, people come into the ER though with some chest tightness or heaviness, or they can't take a deep breath, well, because everything's swollen. It's an infection. Everything's inflamed. Okay. And when you start to see that stuff, you know there's an issue. So the one thing that is wrong on this slide is that now the American Heart Association wants 3 blood cultures. So please change on the side. It says 2, right under it says Duke major criteria. It says 2 positive blood cultures. Please scratch out and put 3. And then they're gonna, if that's positive, when all this stuff's going on, they're gonna do an echocardiogram, okay? The echocardiogram is you're gonna be able to see the vegetation in the heart. And then a new regurgitated murmur. So you have children that get born with murmurs all the time. Some they didn't close all the way, they're fine. They're completely fine. They'll, if there was an issue, it would have been fixed a long time ago. That's not what we're talking about. My 9-year-old daughter had a murmur until a couple years ago. But this is something where they came in, the patient is completely healthy, nothing wrong, all of a sudden they have a murmur. If that is the case, if they've said, no one's ever told me I had a murmur before, that is a huge red flag. Something is going on, the heart's starting to fail. For the minor criteria, a predisposition, someone say that word for me.
Predisposed.
Thank you, condition, so what we talked about with the heart stuff, all right, a fever, I know, it's flu, cold season, everyone has a fever. Immunologic signs, so their immune system's starting to break down. 1 positive blood culture, please change that to 2. And then the positive echo.
So for the murmur, are they, besides like listening with the stethoscope, are they going to do any further tests to diagnose that?
They'll
or
do
is
the
it
echo,
just
they'll do the echocardiogram. The echocardiogram pretty much be able to tell us everything we need to know after that. When it comes to endocarditis, an echocardiogram will tell us more than a CT scan. All right, you want to see it? There it is. That's it. See, it looks like cauliflower.
And where exactly is that?
It's in the aorta. This particular one's in the aorta. Yeah, it grew from the heart muscle.
Yummy.
It's very serious. So, bacterial endocarditis. This is the most common. So guess what? It's the most common, but since it's bacterial, it's the easiest to treat. Because when it comes to viral, we're going to pump the patient full of antibiotics, but when it comes to a viral thing, technically antibiotics aren't going to do anything to viral. You're just going to, yes ma'am.
Can you turn the light back on?
Oh, sure, yeah, go ahead. Thanks for reminding me. I worked night shift for 7 years, I can work in that.
Can't see well.
That's okay.
Okay.
This particular character, this is all I always hate when I have a patient going, I just don't feel right. Oh, crap. Like, something's going to happen, okay? All right, your clinical manifestation. This one's very non-specific. Fever occurs in about 90% of patients, so guess what? You're always going to have that person that doesn't have fever and their body's reacting to it, and it's fighting it, so it's keeping it down. But they will always have chills, okay? They're going to be weak. Why is someone going to be weak?
Because the heart's not pumping.
Exactly. The heart is not pumping sufficiently at all, so they're just weak. Chances are the oxygen is not getting around the system, the red blood cells aren't getting around the system as well, so they're just weak. They're just fatigued.
So are they going to be standing well?
What's that?
Are they going to, their O2 going to be,
Not necessarily.
because they're compensating?
Like, if they're a younger, healthier individual, they're going to be compensating pretty well. And in this case, too, an ABG is not going to tell you anything, okay? So, ABGs don't really come into effect with this. But your big thing is still, the big clinical manifestation change is when they get the murmur, brand new murmur. Because what is a murmur?
An extra.
Oh, a hole?
It's a hole. So if you have a hole in your heart that's never been there before, what's happening? The vegetation's ripping the side of the heart open. Slowly, but it's happening. So this person needs some serious interventions. All right, diagnostic test. So obviously, what's the first thing we do? No.
Echocardiogram.
No.
Ask them questions.
Questions. What part of questions? What's that under?
Health history.
Health history. And what else? What other history do you want to know?
Family.
Family history. Yeah. So if you have someone come in that's 35 and says, you know, I just don't feel like this, and you go through your family history as all these other tests are being ordered, you're like, oh yeah, my father died of endocarditis when he was 36. Ding, 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 ding. Okay. Sometimes doesn't matter how healthy you are. Sometimes genes just get you. So recent dental. Did anything happen? Any surgeries that just happened? Any renal issues that just happened? Any GYN issues that just happened? Heart disease? IV, any kind of IV placement? We've kind of already gone through these, but your laboratory test, how many blood cultures do you need for major?
3.
How many blood cultures do you need for minor?
2.
Perfect. You're going to do a white blood cell count. You're going to do your echo and do a chest x-ray. Why are we going to do a chest x-ray? Because with that vegetation, what's it doing to the heart?
Enlarging.
It's enlarging it, so you're going to get the enlarged heart. Perfect.
So you said before it could be ripping a hole in it.
Mhm.
Could you get like bleeding out?
It's what happens with endocarditis because the vegetation's the one ripping the heart open, but when it's ripping the heart open, it's replacing it with the vegetation. So there's very little outside leakage. Oh, still not good, but outside leakage. So sometimes when we go in and try to get the vegetation out, we're also resewing the heart back up at the same time. That particular surgery is not a cure to going in and stripping the vegetation out. That's just giving the patient some extra time for us to be able to see if we can treat it. Okay, it's not a fix. Collaborative care. What are you going to do as a nurse if you have a patient with endocarditis?
Antibiotic treatment.
Absolutely. And how do you know what antibiotics the doctor's going to be ordering?
From the blood cultures?
Okay, perfect. But blood cultures take how long to get back, roughly?
2 to 3 days.
Yeah, about 72 hours. So what are you going to do in the meantime? What antibiotics do we typically give while we're waiting? Broad spectrum, very good. Broad spectrum antibiotic. So you're going to want to get those blood cultures first before giving the antibiotic, especially the broad spectrum one. Because if you give the antibiotic, just one dose of antibiotic can completely skew your blood cultures. Okay? And if they have a fever, they'll be okay for a second. Get the blood cultures and then give them some Tylenol, okay? They'll be fine. It is very important to get these blood cultures going. All right. Pericarditis. What is pericarditis?
Infection of the pericardium.
Inflammation of the pericardium.
There you go. And what is the pericardium? What does it enclose?
The heart.
The heart. So it's inflammation of the heart sac. Okay? So a very thin layer that wraps around the heart. And there's very, very little, tiny little room between the heart and the sac. So if all of a sudden this sac is inflamed, guess what's happening to the heart? It's being squeezed. So what is your patient going to look like?
Short of breath.
Hurting.
Hurting,
I'm
yes,
not
they're
sure
going to
of
be. No, they can be short of breath. It's infected. And guess what? That heart and that lung, they're butting up against each other. They're rubbing up against each other. So they could have some shortness of breath. Chest heaviness, uncomfortableness.
Friction rub.
What's that?
Friction rub.
Little friction rub. Remember what friction rub is from health assessment? They can also have an impending feeling of doom. This is a real thing. Where you have patients that come in and just like, I just feel like something bad's going to happen. They're not wrong. Something bad's happening. Okay? Now, if it's an acute problem, you have severe chest pain. So they're going to kind of look like they're having a heart attack. Except when you hook them up to the monitor, their EKG is going to look fine. Okay? Your EKG is not going to change with an infection. It's just, remember, EKG is just measuring electricity. So it's not going to change. See dyspnea, Brittany, you're right. And then the friction rub. For a chronic, yes, you can have someone with chronic infection of the heart sac, okay? That you can have for years and years and years and be fine. But, so they have a decreased CO. watch this very carefully. Dyspnea on exertion. What does that mean?
When
Whenever
they're
you're
sitting down,
moving.
they're just.
Yes, when they're moving. Yeah, exactly. Brittany's right. They're sitting down, they're fine. They look absolutely fine. Everything's fine. You want to get them up and walk around the unit. Now they look like they need non-rebreather on. Okay, that is very important. So if you're going to give someone treatment for pericarditis when they have dyspnea on exertion, you give them the treatment. How are you going to measure it's getting better?
You didn't walk around.
Get up and walk around, see if it's getting better. That is how you measure it. Okay, when it comes to something like this, you can't just ask the patient if they're feeling better, especially if they're just sitting there. You need to be able to have a measurement for it. Peripheral edema, the edema is not going to be horrible, but you're at least going to be able to push down and see that there is some edema going on there. Ascites, where does ascites like to hang out?
In the abdomen.
In the abdomen, close to the liver. Again, they're fatigued, they have anorexia, they have weight loss. Because they're fatigued, you're losing your appetite. Ricky's throwing her own sunglasses. Those are nice too, man. Okay, and then jugular venous distension. Why are these distended?
Because the heart's working.
The heart's pumping really hard to do minimal work.
When that happens, you can see it.
You can see it.
Okay.
Yeah, it's fairly pronounced.
I think if I go like this,
I'm gonna
you
Google
can
it
see
tonight.
'em.
I just saw a video on it on Instagram. I should like when we were sitting together. I should have showed you. Instagram.
So if you have a patient that's having some difficulty breathing, what is the first thing you can do as a nursing? As a nursing assistant?
Sit 'em up.
Dang it.
Rebecca, sit them up. Sometimes sitting, all you have to do is sit them up, you don't need oxygen. But that's the first thing you can do, you don't have to worry about order or anything, unless they're on like strict bed rest. But I can guarantee you, any doctor, if you say, this is what's going on, they couldn't breathe, I got them up and they're sitting at the side of the bed, doctor's like, whatever, fine. How they do, okay? It's important to get them up, because once you set them up, the diaphragm can open up, they can take a deep breath, which can help oxygenate the heart a little bit better. Then after that, if you would like to, or if it's not working, throw some O2 on. All right, complications. What are some complications that you never want to see?
Fluid accumulation.
Fluid. Excess fluid about the pericardium. This is bad. Excess fluid that's built up because of the infection is going to cause something called cardiac tamponade. Cardiac tamponade will kill your patient. It's not a thing that's going to happen in a couple minutes, but you only have a couple hours to fix this. So if they have cardiac tamponade, we have to take them into surgery. Okay, this is an emergency surgery. What do you think we're going to do?
Drain it
How are we going to drain it?
carefully.
Carefully. Yes, carefully. She's right. We are very careful.
Pericardial synthesis.
Close. In this case, a pericardial window. We are literally going to cut a square in the pericardium and let it drain out. And it's completely right though. If there's an excess amount of fluid that just keeps coming because of the infection, we can put a small drain in and close up, okay? I have had a patient, all right, so think of the heart, think of that little sac around the heart, right? How many milliliters of fluid do you think's in there in a normal healthy heart?
Not a lot.
20.
About 10, okay? It's a very thin layer. If I told you I had a half a liter out in a patient once, we don't even know how she was still alive. My cardiovascular surgeon, when he started draining her, he goes, I don't even know how she's still alive. So, that was a very stubborn heart. All right, diagnostic test. What are we gonna do? Yes, ma'am.
For cardiac tamponade.
Yes.
Last week you said it was because of a trauma or something else.
It
This
can
is
be.
just like another.
Yeah, it's just another
Reason?
way to get correct. Anything,
Okay.
when it comes to cardiac tamponade, anything where there's some kind of trauma to the heart. Well, if you have an infection going around the heart that's squeezing the heart,
It's traumatic.
it's traumatic. Yep.
Okay.
All right. You do not need to know the EKG stages of this, but I put them up there. This is why when it's really early, people think the patient's having a heart attack when it's not the case. Okay.
I was gonna ask if we need to know what his name
No, no. It's just there. You don't need to know the stages. That's not important right now. Of course, we're gonna get the echo. Then we're gonna go to CT and possibly MRI, just to get a better idea. Again, with the chest X-ray, that's just seeing if the heart's enlarged, and the different labs. Those are they're infection labs and they're cardiac labs. Because this can lead to a full-blown acute MI, okay? Enough stress in the heart, part of the heart will die and you'll have a full-blown acute MI. Yes, sir?
Can you touch on the C-reactive protein and why they would order that? You see that ordered a lot never really fully understood.
Well, what is it? What is C-active protein?
It's one of those that comes out with infection. It's not.
It's
I
an
know
infection
exact-
measurement.
Yeah, I know
Yeah.
exactly what
And,
it is.
it'll be able to tell the physician and the nurses how bad the infection is. Are we in like the stage 1 where maybe it's not so bad, we got time, or is it in stage 4 and you're like, oh my gosh, the heart's like about to shut down. So
What's ESRM? Isn't that separate?
it's a set rate.
Okay.
Same thing with
And
infection.
Okay.
Basically, they all go up. Okay, makes sense? All right, nursing and collaborative management. So acute. What is the first thing that we typically will treat with this patient? And no, it's not an antibiotic.
Pain.
What?
It says pain. on
Pain
it.
and anxiety. We gotta get them under control. Because all of a sudden, if you walk in and you say, "All right, Miss Anna, we know exactly what's going on," and your heart's infected, I don't think she can be like, "Yes." No, she's gonna freak out. Okay, so we typically have options for a little bit of pain medication, a little morphine, and maybe a little bit of Xanax, just to help them. Okay. I know that's not how I would present this issue with the patient. Head of bed up about 45 degrees. Okay. Just keep their head up for a little bit, even if they're not having any issues right now. It's going to help prevent any issues. They are not allowed to drink alcohol.
Oh.
Okay.
Ever?
I would venture to say if they've had this done, if they don't follow some of the orders, it will come back, and alcohol is one of them. Yep. We possibly might do a paracentesis, which is we take a very long thin needle and we put it through the chest wall. We use an ultrasound to do this, and we drain out the excess fluid. Okay. So how do you think we decide if we're going to do a pericardial window? We're actually going in and cutting a window out, or we're going to do a pericardiocentesis.
Depending on how much fluid.
Condition of your patient, very good, and how much fluid you got. Or is maybe the fluid in one little area where you can just put the needle in and get it all out. That's why eventually we'll have to do a CT and MRI just to really narrow it down. Right, myocarditis. What's this an infection of? Myocardium, or the bottom side of the heart, right? The heart muscle that's really pumping what's going on. So unfortunately, there's multiple causes with this. Can be viral, can be bacterial, fungi, radiation therapy. So you're typically going to see this in cancer patients. Or what else?
Drugs.
Hmm?
Drugs.
No, not radiation therapy.
Oh.
Just so you think radiation therapy.
Oh, like people who work in those environments, military or
Military, SSR,
SSR.
the old, the reactor in Russia that blew up.
Oh, okay, yeah.
A lot of people had this.
Wouldn't the
Chernobyl.
cancer patients, it would be able to, they would find it right away because
You would hope
hopefully
so.
they're being
You hope so.
watched.
There's been people on the Reagan, they went to Japan to help out,
Mm-hmm.
and they're coming back with cancer.
Yeah. Mhm. Because I don't care what anybody says, a little bit of radiation can kill you.
Mhm.
That's why when you are working in the hospital, if you're working in the ER, if you're working in the OR, if you're working in the cath lab, please don't be a hero. Please put your shields on, okay? Especially your thyroid shields, because do you know the number one cancer of medical professionals?
Honestly, thyroid.
Because we'll go put our lead gowns on, right? We're like, oh, we don't need the thyroid shield. I've had people do this all the time. This is my gown. They'll just do this. You walk around like this all day? No, it doesn't work. Okay, and thyroid cancer is on the rise when it comes to healthcare professionals, because we're big and bad and we don't think radiation is gonna get us.
If you're working here, don't you have to have the monitor?
Yeah.
They
And
don't
if you're
have
pregnant,
us
you have
with-
two.
It's like they don't have us in my ER. We don't have those. I
By
wish we
law,
did.
they should.
All
By
right.
law.
Let me bring it up.
What?
What shields?
The lead shields? There's literally, depending on what units you work in, you're gonna have lead shields. They're huge aprons that you put on. They're very heavy, and you put them on for X-ray purposes.
Oh, we
that's
have a
what
whole
you're
separate
talking
room
about. I know
in
what
the
you're talking
ER
about.
for
There's
X-ray.
Okay.
more
So we
than
would-
an X-ray, they put
okay.
on that heavy thing
Mhm.
over you.
Okay.
I know.
We do it a lot, especially if we're doing like a chest X-ray, and let's say
Oh, we have
the
portables.
female or
I
male
understand,
is
yeah.
still of birthing age, we'll put a shield on their abdomen and wrap it around just for some extra measure. Okay.
Mm.
Especially with the little ones. All right, so clinical manifestations. What you got?
Fever, fatigue,
Mhm.
malaise, malaise.
Myalgia.
Mm-hmm.
That one.
Laryngitis.
Laryngitis.
Dyspnea.
Mm-hmm. Lymphadenopathy.
Mhm.
Anybody know what that is?
No.
I'm assuming something with the lymph nodes.
Yeah.
Lymph nodes. Opathy.
Enlarged.
Mm-hmm. So when it comes to these 3 different infections, how do you know which one's which? Very similar signs and symptoms, yeah? So how do you know
Where it's located.
where it's located? That's why you need your scans done. That's why you need your echocardiogram done. That is going to tell you where it's located. So again, diagnostic test. Pretty similar, right?
Mhm.
Yep, the big thing is your scans. So, your collaborative management, assessments for heart failure. What, you guys remember at all what your signs and symptoms of heart failure are?
Yes.
For right side?
For which one?
Either side.
Oh, tons. You have
Okay,
edema,
so-
pulmonary edema. You have
Restless.
That's 2.
Yeah.
Restlessness, tachycardia, ascites.
high or low blood
TBD.
pressure.
Hepatomegaly.
Good. So all of those. And it won't stick to one side or the other because it surrounds the whole heart wall, so we don't know which one's going to be affected or if either of them is going to be affected. Again, keep them in semi-Fowler's position. If they're looking a little bit anxious, see if you can get something for them if they want to. And then prescribe medications as ordered. All right, valvular heart disease. There's a little diagram of the heart. Okay. So, what do you know about valvular heart disease?
It affects some valves.
There you go. All right. Can you guys see these 4 decently up there? The normal valve open, normal valve closed.
Mhm.
All right, so letter A, normal position of the valve leaflets, okay? Open, so blood's going through. Normal valve closed. You see how it's kind of went together as a zipper? That's what you want. When it comes to C, mitral stenosis, it's open. Look at it when it's closed. When you have stenosis, you get the regurgitation. So when it's closed, is it really closed?
No.
No, that's where you get your regurgitation from, okay? It looks more closed on the open than it does the
That's what I was
closed.
about to say.
It does. And that's why you get the regurgitation. What is regurgitation? What's happening?
Going back.
It's going,
It's going
back.
backwards. All right, stenosis. Valve orifice is restricted. So how are some ways people get stenosis?
Like the fatty.
Mm-hmm.
Increased
What?
cholesterol.
Lipids,
smoke.
yeah.
Lipids, high lipids, electrolytes, lipid. Cholesterol, thank you. High cholesterol. That is one of the biggest ways. What else can be restricting the valves?
Like cow.
What?
No, I don't know what I was gonna say.
Clot.
A clot. Maybe a clot got stuck. What if the valve collapsed? Weak valve collapsed. This impedes forward blood flow. Make sense? That's why you get the regurgitation. It forces it back. And the regurgitation is the incomplete closure of a valve leaflet.
So then would you have a chance for then clotting because of the stenosis?
Yep.
Okay.
Because it only push so much blood through at one hit. So doesn't matter if it opens correctly or not the next time, you're not going to be able to get all that blood through. All right, disorders in children are primarily they're born with it, okay? Some adults, not many, and it's still usually a genetic thing that catches up with them, can form a cardiac disease, but it's rare. All right, this is stenosis. What do you think? That heart look good, look bad? That is a ridiculously unhealthy heart.
Is that a really fat heart?
Yeah.
Okay.
Mhm.
Like all that yellow around it is
Mhm.
fat. Oh my goodness.
He's just fluffy, Brittany, jeez.
I'm so sorry. Is that a
Well,
fluffy
my
heart?
heart is
So
fluffy.
sorry, everybody.
To offend somebody.
Mm.
Okay. I didn't say that. Majority of adult cases from rheumatoid heart disease, okay? It's a breakdown of the heart, it's a breakdown of the muscle, just like any other muscle. The heart, that is what the heart is. So, mitral valve stenosis. Clinical manifestations, here we go. Again, exertional dyspnea. In this case, the reason they get exertional dyspnea is a reduced lung compliance. Heart's not working, so the lungs are being lazy, okay? They might get palpitations from AFib. This type of patient can go from afibrillation to normal sinus rhythm, to afibrillation to normal sinus rhythm. It's very common for them to do that. Accentuated first heart sound. So S1 is very, very pronounced because when it's trying to open, it's boom, S2, boom, S2, okay? It's trying really, really hard to get as much fluid through that small opening as it can. But then on the other hand, you'll get the low-pitched rumbling diastolic murmur. So where is that hanging out? S3 or S4? Where's the murmurs hang out? S3. So you're gonna get that real, like that rumbling S3. So you'll hear the boom for S1, normal S2, a rumbling. Boom to S1, normal S2, a rumbling. Very, very common with mitral valve stenosis. Hoarseness. Why would someone have hoarseness when they're talking with us?
Because they're straining.
No, it's not hoarseness, not hoarseness throat. You can actually hear it in the heart. I'm sorry, I just messed with you.
Oh,
No, it's actually kind of a rubbing sound in the heart that you can hear throughout. Make sense?
Yes.
All right, let's talk about regurgitation now. We already know the definition of regurgitation. Okay. Majority cause attributed to an MI, so a weakened of the heart, a weakened muscle of the heart. It's very common to get this after an MI. A chronic rheumatic heart disease. A mitral valve prolapse, that makes sense, right? Prolapses, you're gonna have regurgitation after that, even if after it's fixed. You might see this in infective endocarditis, we've already talked about this. So, clinical manifestation, what's your patient gonna look like? What's their pulse gonna look like? They're gonna be thready. And?
they're gonna be cool and clammy.
Yes, why?
Is it because the blood's not getting through their extremities?
Exactly, the blood's not getting through. And then a chronic asymptomatic individual can have this for years before anybody knows. And by this point, there's not a whole lot we can do, we just manage it once we find out. All right, your initial symptoms include, look at that, weakness, fatigue. Palpitations, so this could be PVCs, PACs, going out of AFib, A-flutter, just regardless palpitations. These are typical people that can actually feel it, because you're all throwing early heartbeats all the time, you don't even feel it. Okay, once in a while, just everything gets crossed and someone decides to throw up an early heartbeat. Dyspnea that gradually progresses to orthodyspnea. What's orthopnea? Sorry.
Difficulty
laying down.
Okay. Why would you have difficulty breathing laying down?
Because your blood's pooling.
So what do you need to do to the patient?
There you
go. Nocturnal dyspnea, and then peripheral edema, okay? This is what a prolapse looks like. Believe it or not, this is a much healthier heart than the first patient. Just got cut in half. So what's wrong? It popped out. And it's not covering the whole opening anymore. Alright. So it's usually benign. So if it's usually benign, everyone knows what benign means?
It's not cancer.
Not cancerous, probably not going to kill you right now. Why do we need to keep looking at this though? Doesn't mean we're just gonna be like, oh, it's fine. Come back next year for another checkup. We're gonna be watching
Can
this
develop into something else?
because it can develop into something else. So occasionally we do have to go in and fix it, but if we don't have to, especially with the kids, we're not going to. Do you know why we try to just do non-invasive treatment with children?
Because they can
Probably
most
fix
likely fix
itself.
itself.
They can't handle it?
No,
Is it 'cause it's still growing?
because it's still growing. Heart's still growing, which means you're gonna go in there often and refix it, okay? So mitral valve prolapse. Why does the pain not respond to anti-angina treatment, which means morphine doesn't do anything, nitro doesn't do anything?
Because you're not doing anything to fix the prolapse.
Yeah, you have to actually at this point fix the prolapse. Okay. Nitro might help a little bit for the vessels around the prolapse, but it's not gonna do anything with the prolapse. The muscle's too weak to do anything at this point in time. Good job. All right, why don't we take a break because we're at aortic valve stenosis. All right, go take 15.
TMI.
All right, aortic valve stenosis. Oddly enough, very similar to mitral valve stenosis. I know, shocking. All right, you see the normal opening, the normal closure, the aortic valve stenosis opening, and the normal closure. All right, so what's the difference between the opening from a normal valve to a stenosis valve?
It's not opening all the way.
It's not opening all the way, it's a little constricted. And the difference between a closed normal and closed stenosis?
It's not closing.
Yeah, it can't close all the way. Very good. That's how simple it is. All right. It affects the left ventricular hypertrophy and increases myocardial oxygen consumption. So what does that mean? Why is it consuming more O2 than normal?
It's working harder.
It has to work harder, so it needs more O2. So what is your patient going to look like?
Out of breath. Oh.
Blue?
Cold?
That's what they're gonna
So
do.
read your slide.
Rapid shallow breathing.
Out of breath when you're moving.
So exertional dyspnea
Yeah.
and
See.
syncope.
What is that?
Syncope, dizziness,
Oh,
lightheadedness, dizziness.
so many fancy words.
I know, all this medical jargon. So why are they getting dizzy? Why are they getting lightheaded?
Because it all their brain.
Yes, because the heart's stealing all the oxygen and there's not enough getting up to the brain. It's really that simple. And angina? What's angina?
Chest pain.
See, that was medical jargon. You knew that one.
I didn't answer it.
I always thought it was syncope.
Syncope? If you said syncope, we know exactly what you're talking about. All right. There's a poor prognosis. Why is there a poor prognosis with aortic versus mitral?
Because that feeds the heart and the other one feeds the
Mhm.
body.
Does that make sense?
Okay,
When you're
so
the aortic valve stenosis, that's what's feeding the heart muscle. Whereas the mitral valve stenosis, that's what's feeding the rest of the body. So the heart's going to break down faster when it comes to aortic valve stenosis.
So, which one feeds the body?
Aortic.
The one where-
I'm sorry, no, aortic feeds the heart. Mitral
Oh.
feeds the body. Going in, going out. So let's talk about what you're going to hear. Roughly a normal S1. The S2 is either going to be diminished or completely missing. S3, you're going to hear a murmur. and S4 is going to be very predominant. So how many beats could you possibly hear when it comes to aortic stenosis?
4.
4, because you may hear the second, you may hear the S1, you may not. So you could have 4 different. What's that?
What does the prominent mean?
Predominant. So loud,
Oh, loud.
booming.
I need to hear this.
I don't have an S4, so I'm not no help to you.
I want to hear that.
What the prominent?
What it sounds like. No, the whole entire heartbeat.
Oh,
I would find it on YouTube or something.
yeah, we can probably find a
I
video.
want to hear it.
Yeah, it's very, very distinctive. You're never gonna hear anything like it. All right, who wants to read?
During the nursing assessment of a patient with an aortic stenosis, the nurse would expect to find
What's the only one we talked about? A murmur. All the other ones are mitral. Okay, systolic murmur. All right, very good. Regurgitation. This is a life-threatening issue that can kill a patient in a couple hours, okay? What is its main causes?
ineffective endocarditis,
Infective endocarditis.
or infective, sorry,
Right, that's okay.
trauma,
A trauma.
and aortic distension, sorry,
An aortic distension, very good, can kill a patient within minutes. I've opened up patients on the an ER cart when they were dissecting. Oddly enough, not as bloody as you would think, because heart's not pumping. All right, chronic aorta regurgitation. So again, rheumatoid heart disease. So that's prevalent in both, correct? If it's prevalent in both, it's probably nothing you're going to see on the test because there's going to be no way to differentiate it, okay? Congenital bicuspid atrial valve. So who has that? Kids. Kids get that. Congenital kids. They're born with it. They can grow out of it. Syphilis.
So Al Capone died.
Who?
Al Capone.
Yes, this was.
You don't know what Al Capone is?
Al Capone is the
The
big
brains?
No, he died of the heart disease that syphilis gave him, you know.
Yeah, he died of aortic stenosis, but he got it. The rumor, I don't know if they ever did any like actual.
He got syphilis.
Yeah, I don't know if they ever actually like autopsied the body or anything, but that's the rumor. All right, then chronic rheumatoid heart conditions. Again, not gonna be able to differentiate the two, so you're probably not gonna see that. All right. So you guys can read how it flows, or in this case, doesn't flow. So what's your patient gonna look like?
Fatigue.
Fatigued.
Huge fatigue, and it's sudden. It's a sudden onset. You feel completely fine, and it's like boom, like you just hit the floor. So it's a sudden. It's very severe dyspnea, even at rest. Hypotension, so the blood pressure drops. Chest pain, and this is considered a life-threatening emergency. So what's the patient going to sound like? This is also something that's very, very specific to aortic valve rotation. A water hammer pulse. You ever swing a hammer in a tub? Go home and do it. And that's what it's going to sound like.
Do what?
Go fill your bathtub up with water and put the hammer underneath the water and try to swing
Oh, underneath it?
underneath the water.
I thought you were gonna say hit the button.
No. You can. I mean, you have to hit the water to get to it, but no. That's exactly what it sounds like. Okay? So S1, it's either soft or not even there. There is no S2. S3 and S4 are present. There is very often a high-pitched dystolic murmur. So what's dystolic from systolic murmur? Where's this one going to be hanging out? Where's the murmurs hang out?
S3.
S3. I don't care if you understand what Austin Flint murmur sounds like, it's just a murmur, okay? No. You're not gonna be able to differentiate this in your career now. The chronic regurgitation, which means the patient has it, but it's not life-threatening at this time. Patient can have it for years. They have the exertional dyspnea again. The shorter breath when they're laying down, and then the dyspnea when sleeping. So tricuspid valve stenosis. What is the tricuspid valve stenosis?
Narrowing or stiffening of the opening in the valve stenosis.
Exactly. Where is it more commonly seen and what type of patients?
Drug abusers or the IV ones.
Mm-hmm. This is what we're typically seeing in drug abusers right now. So, diagnostic studies. How do you find out if someone's abusing drugs?
You can probably see their arms, their
Tracks.
people.
Ask them.
Ask them.
Oh, yeah.
Just ask them.
Sometimes they don't tell you though.
Most of the time they do.
You always ask me to drink alcohol, I say no. I don't do it often.
Do drug users typically tell you they use more or less?
Less.
Why?
They don't get arrested or in trouble.
Nope. You guys are wrong.
Judge?
Because they don't want to seem like they have a
Nope.
problem.
You have a chronic drug abuser, someone that wants to get high. Are they telling you they take more or less than they actually take?
Oh, because they want you to give them the dose that's higher than what they take.
They will tell you they take more. Because then you're going to plan on, so let's say they inject heroin 3 times a day, or 3 times a week. That doctor is going to order a ridiculous amount of narcotics. Why?
Because their
tolerance
withdrawal
is
is going to
high.
be crazy.
The withdrawal is going to be very severe if they're telling the truth. So that's when you need a very seasoned veteran nurse that can tell if the patient's actually withdrawing or not. So if I walk in, the patient goes, I need something, I'm withdrawing, and they're completely calm and fine, and their respirations are fine, and they're not diaphoretic, I'll be like, yeah, you're good right now, okay? Why don't you just sit back, relax. But if I walk in, and they're shaking, they're trembling, they're diaphoretic, their pupils are dilating, they're going a little bit crazy on me, yeah, you need to give them something. And I've done 15, 20, 25 milligrams of morphine in one hit with these patients. Because you need to get them off of the high, but you can't just stop them. Because you know what happens when you stop someone that's constantly high and you just try to DT them?
They're gonna die.
How? Something catastrophic is gonna happen. What happens?
Shuts their body shuts down.
Is it with their
The heart. Someone said it.
Yeah.
They'll have a heart attack. It's a stress-induced heart attack, and they will have a heart attack, and typically they will die.
When a patient comes in with drugs, do you tell like the police or anything?
Nope.
No. Okay.
No, I'm not doing
Nope.
that.
You're not supposed to do that.
I never knew.
You have more important things to tell, because if the police come and try to arrest them, they go through DTs in a jail cell, they'll die. That's what has happened several times, where somebody has died in police custody, and there's a huge uproar, and I understand that, but a lot of people don't understand that if they were detoxing, there was absolutely nothing the police officer could have done. They are going to have a heart attack and they're going to die. And I know plenty of police officers that picked up a patient that looked bad, so they just brought him right to the ER because they didn't know what to do. And that's the appropriate thing to do. But that's what's happening a lot around the country, especially with the heroin and cocaine. You can have somebody that looks absolutely fine, but it doesn't take long for them to start going to DTs. And just like the nurses, the paramedics, the police officers, the firefighters, they're all overworked too. Okay, it's not just the nurses, and they're gonna miss cues too. And they are not, police officers, even though they know CPR, they are not trained as a medical professional. So they're gonna miss those subtle things that as a nurse in a couple years, you're gonna pick up on like this. They're not trained to do it. So they could just think, oh, the person in the back of my place is back of the car in the jail cell is just acting up. They don't understand those little cues, okay? So, diagnostic studies, yes, absolutely, you just ask them. Most drug abusers will tell you, and they will tell you that they take more than they actually take. Because they know your drugs are pure and you probably won't kill them. I say probably because sometimes it happens, okay? Chest x-ray again, want to see if they have anything enlarged with the chest going on. The aorta is large and with cocaine. ECG, EKG. See if there's any changes, and then a cardiac catheterization, possibly. That's your last step. And it doesn't necessarily mean you're going in to put any kind of stent in. You're just going in to look at the heart. Collaborative care. What are you going to focus on with the patient?
For which patient?
For the patient with.
Preventing of recurrent rheumatic fever.
Yep. So how do you prevent a fever or endocarditis?
Tylenol if it's too high.
And then
That's not going to prevent an infection.
would that be
Antibiotics.
antibiotic?
Possibly. Go a step further. How did they get the endocarditis in the first place?
Oh, tell them, like, brush their teeth.
Yeah, you need to go back to why they got it.
Oh.
If you know why they got it, okay? And a lot of the times it's as simple as you need to go see a dentist, need to go see an oral surgeon. I know it sounds so like mundane and simple, but that's why we're getting these patients a lot, where they're fairly healthy, but their gums and their teeth are just wearing down. Acute pulmonary edema. Remember when we talked about pulmonary edema? Vaguely, kind of. I like
Yeah.
two people kind of go, yeah, okay. All right, just make sure. Thrombocytopenia. I'm sorry, no. Oh, no. It's not the same thing. Thrombocytosis. Throwing clots of what? Not blood. What is that? Fat. It's fat. Okay. And then reoccurrent endocarditis. Collaborative care. So how are you going to work with everybody else? What do you want to do?
Different diet,
What kind of diet?
cardio.
Low sodium diet. What else do you want to do?
Medicate.
Possibly medicate. What kind of meds is this patient possibly going to be on?
Blood thinners,
Blood thinners, absolutely. Why?
the clots.
Because of clot risk. What else?
Beta blockers.
Beta blockers. Why do you want them on a beta blocker?
That helps.
Increase cardiac output.
Increases cardiac output. Gets the heart beating harder, not faster. You don't want the heart to beat faster. You want it to beat stronger. Why do you want them on a possible diuretic?
To,
If there's pulmonary
for
edema.
Pulmonary edema. If they're on pulmonary edema, they're going to be on diuretic. Vasodilator.
We gotta have,
Blood
treat
flow.
big
angina
arteries
and
for
control
all
blood
that blood you're trying to increase.
Relax those blood cells. Get that blood vessels. You want that blood going in faster. Okay. Is that making sense? Kind of depending on what the treatment is why they have the disease in the first place. You always need to narrow down why they have it. All right, this is a picture, just different, the balloon process when we're doing a cath. I always thought it looked like a peanut.
See, I thought it looked like a sperm in the first one.
I see that. Oh. So we put it in, and then we just start, you blow up one side, you blow up the other side, and then you blow the whole thing up. Okay. All right, these are just different therapies that are used. In the pictures, they look a lot bigger than they are, but these are, hi, Olivia, are you okay? These are tiny. These are like this big, okay? But in the pictures, they look a lot bigger. We actually can put different devices in that will close and open up mechanically. So if you have a mechanical contraction in your heart, what do you think you're going to hear when you listen to heart sounds?
Clicking.
You're going to hear it clicking. That's when you know it's mechanical. All right, nursing. What are you going to do?
Discourage smoking.
Good job. What else?
Avoid strenuous activity.
Mm-hmm.
Assess the heart to breath sounds.
Good.
Recommend a medical alert bracelet.
There you guys are catching on.
Life alert.
Life alert.
Teach the importance of completing an antibiotic regimen.
Okay.
Teach the side effects to look out for.
All right, so let's talk about side effects. One of the big ones we give is anticoagulants. So what are some side effects of those?
Bleeding.
Bleeding times, right? Their bleeding times could go up. So if you have someone that's going to be on lifetime anticoagulants, what do they need to be doing on an annual basis?
Getting their blood.
Getting your blood tested, okay? Just like afibrillation patients are on Coumadin, I know patients that have to get their blood checked weekly when they first start out, and It's not that severe when it comes to a mechanical valve, but for the rest of their life, they will need annual blood testing. Because we're not just checking blood levels. Anybody else know what we'd be checking for? Remember, it's a mechanical valve.
So,
Leaks?
Hmm?
Leaks?
Reject metal.
Well,
Kind of rejecting it. We put something in the body that was not supposed to be there. Infection. It's a big source of infection because the body may reject it and try to push it out. Or they'll send all the little white blood cells to it and try to eat it up. Okay. Oh, sorry, I hit it twice. All right, circulation problems, which narrows the arteries, which reduces blood flow to your limbs. What are some examples of these? Just think out loud.
atherosclerosis.
What's that?
Atherosclerosis.
Yup. What else? That's the leading cause. But what other things can decrease blood flow to the limbs?
Would be like a
Diabetes. Peripheral artery disease, peripheral vascular disease, any of those, okay? Any of those can cause some serious problems. So let's talk about some of these general issues. Typically occurs in patients 60 to 80s, okay? This is typical. It's not the golden rule. It's largely undiagnosed. Why is that?
because people don't think it's a problem.
People don't think peripheral artery disease is a problem. Do you see it? Do you know that you can see it on pretty much everybody? Because what's one of the number one physical signs that you have PAD? Nope.
Under the veins. Sir.
Varicose.
Varicose veins. And yes, it can, because it can cause damage. A typical little block of varicose veins here and there won't do anything, but when you have a lot of it, because what is a varicose vein? What's happening to all those veins?
Stopping them.
They're new connections. There's a blockage somewhere, a decreased flow somewhere. All those varicose veins are little connections where the vein's trying to go around that spot and can't get completely through. So you know your heart can make a new chamber for itself if one gets blocked. Do you guys know that? Yep. You get a blockage with heart that's a chronic thing, never diagnosed. You had the heart attack, it was completely blocked. Your heart will develop another passage. You give it enough time. I do heart surgery on people all the time where you're like, hey, that's different. Because it is, okay? I don't really care if you know what arteries affects. Guess what? It affects all the arteries from the hip down. They're okay, right? So, what your patient's going to look like with peripheral artery disease? What's it going to look like? Cold feet and hands. Why is that? Why is your fingertips cold? Why are your toes and feet cold?
Circulation.
The blood circulation's decreased. Why do you have a weak pulse?
Blood circulation.
Same thing. All right, painful muscle cramping after activity.
Well, there's not enough oxygen getting to them because there's not enough blood circulating, so obviously they're probably getting hypoxic muscle.
So what can they do if they still want to work out? And they should.
Drink pickle juice.
pickle juice.
Really?
My brother played college football, and that's what they drink in the sidelines and the.
Because of the electrolytes?
Stretch.
Yeah.
Yeah, he's like, you got your cramp, they chug.
But that's a little
Pickle juice.
different than having PAD. I don't think any of them had PAD. But someone said stretching will help. Why does stretching help?
Opens up the muscle.
It relaxes the muscle, it stretches the muscles and makes them leaner. You make your muscles leaner. The vessels have a little more wiggle room. Okay. Change in color, the same reason. A little stenosis in your fingers. Numbness, the same reason. Weakness. Sores that won't heal. Okay. The oxygen, the nutrients aren't getting where they need to be. So hair loss and slower hair growth. A lot of people that are losing their hair is because they're finding out they have PAD. Slower nail growth, same thing. And erectile dysfunction, same thing. Okay.
Different chemical in McDonald's fries that helps with
I
hair
saw
loss.
that.
I think they put a lot of chemicals in McDonald's fries.
So good though.
Alright, complications. There are some serious complications when people want to ignore PAD, okay? What do you think the most severe complications are? What's that? Amputation, yep. Because eventually, that little scratch will turn into a big sore that will turn into gangrene. And then we're going to take whatever limb is going on, because gangrene can spread rapidly within days. You guys can read that if you want to. All right, diagnostic tests. What tests are we going to do for PAD?
Ultrasound.
A Doppler. What is a Doppler ultrasound?
Like when you're pregnant.
That's of your vein.
They're all over.
Oh, to make your
Your
it
pulse
could
is
be
all over your body?
legs.
Even if you can't palpate one, you can take a little Doppler. We have one in the lab if you want to look at it, and you can Doppler the pulses. So when we have people that have severe PAD, let's say in their and we're trying to get the pulse in their Doris, we'll put a little ultrasound gel where it's supposed to be. And I say supposed to be because weird things happen. And then we can typically ultrasound it. If it's true, I've had this happen, where I've had a nurse come to get me and be like, I can't find the pedal pulse at all. All right, let's go and look. I can't find it. Call the PA. PA can't find it. At this point, we're calling the CV surgeon going, it's gone. We can't find it. Please come up here. And we've had limbs removed. Because by that point, that foot is dead. When there is no more blood getting to the foot, it is a dead foot. Same thing with the leg, a hand, anything like this. Okay? There are a couple stent procedures. There's one doctor up at St. Mary's Columbia that is doing them to open up the vessels. But right now, he's one of the only people in this area that's doing it, and it's still very experimental. Because if it messes up, you'll lose your limb. And the arteries going down to your foot get smaller and smaller and smaller and smaller. So you can only get so far. Let's see, Doppler imaging, angiography, kind of like a CT, and then an MRA, okay? All right, risk factors, collaborative care risk factors. So what do you want to what do you want to encourage your patient to do?
Stop
Oh
smoking.
my gosh, yes. Everybody just stop smoking. I don't know. Apparently, according to my slides, the world would be magical and unicorns would show up. I don't know. Aggression treatment of hyperlipidemia. So what's hyperlipidemia?
Too much fat.
Too much fat. Maintain a blood pressure of 140 over 90 or under. So what could they possibly need for that?
Blood pressure meds.
Blood pressure meds.
Low sodium diet.
Yep, low sodium diet. And then if they're diabetic, less than 7% A1C. Okay. Drug therapy. So, anticoagulation. Aspirin and Plavix are typical the drug of choice when it comes to PAD. We do like to use ACE inhibitors. We typically do not use beta blockers. Any questions there? It's pretty self-explanatory. All right. Exercise therapy. Walking is most effective for effective exercise for individuals with this. Why is that?
Because it helps
Blood flow.
Mhm.
Non-weight bearing.
What's that?
Oh, never mind.
Okay. Gets somebody up, gets their blood flowing faster, gets the oxygen moving faster. Okay.
When teaching a patient with peripheral arterial disease, the nurse determines that further teaching is needed when the patient says,
See?
Everybody agree? Absolutely, it's C. When a patient has PAD, it can't necessarily be fixed, but someone can severely make the disease process slow down just by walking 30 minutes a day. So if you have a patient that goes, yeah, I walk 30 minutes a day, or I'm outside 30 minutes a day and I take a walk, but I sit down 15 minutes of that 30 minutes, are they doing the 30 minutes? No,
15.
they're doing 15 minutes. So some of the reasons you get is, well, my feet were hurting, they're numb and tingling. I totally get that. So what should they do?
Rest for a minute, then go back to
Right.
walking.
Fine, walk 5 minutes, sit down for 5 minutes, walk 5 minutes, but they need to be walking for that full at least 30 minutes, and you give it a couple weeks, and you'll hear back that they're able to walk for the full 30 minutes without any pain. Okay? All right, nutritional therapy. So, in the perfect world where unicorns exist, your BMI would be under 25.
My boyfriend's a 6.
We hate her boyfriend.
I hate
My
him
husband's
too.
probably about 8 too. Anyway, that's the point. What are some things that people can change right away without this huge drastic change to their life? Because if you have someone come in and be like, okay, here's 100 things you have to change tomorrow, they're gonna walk out and be like, forget this noise.
Kind of like sugary drinks.
We did something, me and my husband, right after Christmas. We just cut out soda and ice cream. That was it. Just to see for a couple weeks if we did it. I have not had a ice cream since the 23rd of December, and occasionally when I'm feeling down after I've had like a ton of water, because I drink 100 ounces of water a day, I'll have like a Diet Coke or something if I really need a good pick-me-up. He has not had a Pepsi since Christmas Day. And this is a man that had like 6 cans of Pepsi a day. And I'm like, you're gonna cut Wednesday, you're just gonna ooze out sugar. So little things, okay? Sometimes, you need to cut out more, but the reason people don't change their lifestyle is because they're like, okay, it's January 1st, I have this list of 20 things I'm gonna do. Really?
Get over
Really?
it, and then
You're setting yourself up to fail. I don't care who you are. Unless that's all you can do for the next month are those 20 things, you don't have to work, you don't have to go to school, you don't have a life, you're not gonna be able to do it. What are some things that these individuals need to increase in their daily diet?
Fiber.
Fiber? Which comes in what forms?
Beans.
Oats.
Oh, wait,
Oats.
not beans.
Beans are good.
Fruit.
Vegetables, fruit. If you would substitute 1 serving of vegetables or fruit for a serving of something else a day, you would lose 5 pounds a month. It is true. All right, somebody besides Trish.
A patient with peripheral vascular disease has marked peripheral neuropathy. An appropriate nursing diagnosis for the patient is.
Okay, everybody remember what neuropathy is?
Yes.
Does anybody here not know what that is, or you won't be able to answer the question? All right.
would it be 80?
Everybody agree?
Yep.
Yes. Why is it not B? Because theoretically, peripheral artery disease has nothing to do with your skin. That's not the first stage. Why is it not C?
You're not so worried about the tissue perfusion as you are about injury, because tissue perfusion is
Read
going
reread C.
Ineffective peripheral tissue. Oh, they're like the same thing.
What are we talking about? What disease process are we talking about?
Arterial, not
What are we talking about?
PAD, PV.
Not the same thing. Watch your terms. We're talking about peripheral vascular disease. That says just arterial blood. Different things. Different disease process. And then D, activity tolerance. They shouldn't have an activity intolerance policy. They can get up to a regular, to a manageable. All right. Ischemia disorders. What is ischemia? Just generally, what's ischemia?
Lack of oxygen.
Hmm?
No oxygen.
Mm-hmm. Why?
There was a death.
There's a death in what?
Cells.
Kind of.
Tissue.
Why do you read the slide?
Sudden interruption in arterial blood supply to a tissue, organ, or extremity.
There you go. So something blocked. Something blocked an artery. Could be blood, could be a clot, could be fat. Something and it happened rapidly and it causes a ischemia disorder. Now, we're not talking about a neural issue, but if I said that, I can guarantee half the nurses I know would think I'm talking about what?
Oh, ischemic stroke.
A stroke. Okay, we're not there yet. We'll get to neural in a little bit. But, so it is a sudden interruption of the arterial blood flow. So now we're talking about arterial blood flow. All right. Your neurovascular assessment. What are you going to be looking for? Pulse.
Pain.
Pain.
Pallor.
What's pallor?
It's like a white.
Skin color. Very good. What else?
Sensation.
Or paralysis? Can you feel this? Does it feel, what are the two we typically do people? The smooth, is it smooth or is it sharp? It's typically the two we use. And paralysis, can you move this at all? That's really severe. If they, all of a sudden they can't move a leg or a limb, it's gotten quite severe. So those are the 5 P's we use. All right. Inflammation process damage the blood vessel walls. How can somebody help decrease the inflammation process? What can they quit doing?
Smoking.
I'm telling you, everybody quit smoking, the unicorns will come back. Who knows what Raynaud's phenomenon is? Will it kill you?
Turn white and blue randomly.
Will it kill you?
No.
No, it hurts, but it won't kill you. What is the typical individual that can get Raynaud's disease?
Female.
What's that?
Female.
Mm-mm. Can come in either. It's a circulation disorder, right?
Teenagers who text all the time.
That'd be a good threat, but I'm not sure if there's any evidence-based information to back you up. Premature babies that grow up. Because a premature baby, the heart's typically not developed all the way, so they can get, when they're little infants, you'll notice their hands and their feet are really cold all the time. Even if you're like, put them in front of a heater, their hands are still really cold. Well, that doesn't always, but it can develop into Raynaud's disease because the circulation just never shunted up to those tips. Okay? Again, it will not kill anybody, but it can be very painful. So what are some interventions that the individual can do?
Pain management.
Even before pain management, like
Can they-
even
would
to
it
the
help?
top. What's that?
Would it help to just like massage?
Massage. What else?
Isn't
Warm water, but it doesn't want to be very hot. But I mean, even you guys are doing stuff that it's happening. I want prevention.
isn't it typically like
Exercise, keep it, see how much you keep moving. What else? And I know people that have done this. That lived in this area and maybe didn't live in this area anymore. Where'd they go?
Oh, Florida.
Florida. They went somewhere warmer. You go somewhere warmer, your chances of having the phenomenon occur back is less. Simple as that. My grandmother has this really bad, so they moved down to Florida, and what was it like last month when it got to like 40s, 50s down there? She didn't leave the house because it can flare up that easily. So
Well, it gets to 60, it shuts down. 60 degrees.
down in Florida, nothing. And God bless her, she came up over Christmas to meet her granddaughter.
Oh.
Yeah. Okay. Venous thrombosis. Do you guys understand what venous thrombosis is?
That's the non-moving one, right?
What's that?
Is that the one that doesn't move?
We hope not.
Because then it turns into a DVT.
Yep.
Okay.
So you can get a venous clot in the leg somewhere. And then how would you depict if someone has the DVT?
If it moves.
It's not necessarily going to move. A DVT can stay right in the leg. Remember, DVT, if it's a DVT clot,
Edema.
it will stay in the leg. But if it moves, then it goes to like a PE or a TA, depending on where it landed.
They just had surgery and now there's swelling to the leg and it looks painful.
Well, give me your signs and symptoms for a blockage in the lower leg. Swelling, pain.
Red, cold.
What are you guys gonna look for? Cold. What goes on with cold? What do you
Heat.
No.
No
You guys don't want to see if
circulation.
you don't want to see if the tissue's dead. How do you know if the tissue's dead?
Mm.
Pulse. Oh, I didn't hear you. I'm sorry. Pulse. I'm like, come on, guys. Yes, you're gonna check for a pulse. Okay. with this, depending, with the DVTs, depending on where the DVT is in the leg, we can go in with a catheter and blow it up and push it, okay? Depends where it is, because eventually the vessels just get too small and there's no way we can get a line down there. All right. SVT, supraventricular vein thrombosis. Your clinical manifestations. And then VTE is venous thromboembosis. So let's compare the two. In SVT, we have a palpable, firm, cord-like vein. Subcutaneous cord-like vein. Right? So you can move it around, you can push on it, it's all right. In VTE, you have an unilateral leg edema. So what does that mean?
The whole thing.
The effective leg is really swollen and the non-effective leg looks fine, right? Perfect. SVT, tender the touch. So you can palpate it, might be a little uncomfortable, but it's all right. Extreme pain. You touch their leg and they're gonna jump. SVD, systemic temperature. Okay. VTE again, systemic temperature. Same thing, right?
Mm-hmm.
I would toss the two out. I'm not gonna be able to describe both of them. If I put that on the test, I would describe both at the same time. I can answer it. Okay. Leukocytis. So you need a blood test. When it comes to VTE, fullness in the thigh or calf, depending on where the clot is, depending on where the fullness is going to be. Erythema, paracentesis. All right? So those are the two differentiating. Collaborative care of SVT. If it's being caused by a catheter, just a regular peripheral catheter, remove the catheter, get it out of the way. Elevate the extremity. Apply warm heat. Give an NSAID and possibly heparin, but it's something the doctor is going to have to decide. This is very treatable. Okay? When it comes to VTE, a little more extensive. What would you do differently here than you would for SVT? Pretty much everything. This is, which one's more severe?
The VTE.
Yeah, VT is much more severe. This is the blood clot that can cause a limb from being lost, a PE, a stroke. So if you have a patient that medical diagnosis coming in that they have VTE and all of a sudden they're short of breath, what are you gonna do? What's that?
Oh, the VQ or
Possibly the VQ-SAM. Because what are you looking for? What do you think's happening?
The PE.
Yep, they possibly have a PE. This is just, you should just go right to PE. Get some tests ordered, get the doctor on the phone, tell them, okay, your patient came in with this, now they're complaining of chest pain. The doctor's going to start ordering everything for a PE. What are some medications that we'd give for somebody with this?
Anticoagulant.
What's one specifically? Are they, is it too loud? Should I close the door? Okay, just make sure. Heparin and or? You want IV stuff. You want to get it in the system as fast as you can. Heparin and there's one other one.
It wouldn't be TPA.
No, not for this. TPA is specifically stroke. Levinox.
Oh.
Yeah. You would put them on warfarin or Plavix, but right away you get the IV stuff going. Because Coumadin can take up to 7 days to go therapeutic. This patient doesn't have 7 days.
Are there kids here?
There's going to be kids here at any given point in time.
What was the first one you said would be therapeutic before Coumadin? I'm sorry.
Levinox and heparin.
Lebanon.
You need IV. You need to get IV. Because Levinox and heparin will start working within minutes. Heparin's got a 15-minute shelf life. It comes in fast, it goes away fast. So I love heparin, it's a great drug. What kind of food does someone need to avoid if they're on blood thinners, specifically Coumadin? Vitamin what?
Vitamin K.
Vitamin K.
No spinach.
No vitamin K for you. What happens if someone's on a blood thinner and they're eating a bunch of vitamin K food?
It's not gonna make it
Doesn't
work.
work.
It lessens the effectiveness of the drug.
Is this the same thing? So if you keep it constant of what you're eating of vitamin K, but one day you don't eat any vitamin K, then it would increase the effects of
It would
something
increase the
like
effects of
that?
it.
Okay.
Because no matter what, you're gonna have. If you have vegetables or fruit, you're gonna have a little bit of vitamin K.
Right. So
But-
if you stop eating it
Mhm.
completely, then one
Right.
day. Okay.
One day, all you had was ice cream. Yeah.
Ugh,
Okay.
I've had that.
And when it comes to Coumadin, what drug? What blood tests are we looking at? INR. Absolutely. Okay, let's go to deep vein thrombosis. Very exciting. So your etiology of deep vein thrombosis. A trauma, hormones, road traffic accidents, which I think is redundant.
It's trauma.
But operations, specifically a cholecystectomy, which is removing of the gallbladder. Any type of malignancy, so a tumor that's malignant, a blood disorder, obesity, old age, or orthopedic surgery, serious illness, immobilization, so you can't get up, can't move, and then a splenectomy. Any of those can cause deep vein thrombosis. But what's your patient going to look like? Leg swelling.
Pain,
What else?
head.
Yep,
Warmth
yep,
in their leg, like it's gonna be hard for them to move it.
absolutely. So what's their effective leg going to look like?
Big.
Red swollen.
Gross. Brownish color, edema, eczema.
What's it going to feel like?
It's hard
Hard, it's tight, it's leathery.
and it's gonna be pink.
Jasmine, your patient, his right leg. This is it.
Yeah.
Mhm. Yep. He's had a lot of treatment, so the pain was gone, but everything else was there. All right, care, compressive therapy. What's our biggest compressive therapy we use in and out of the hospital?
Tettos.
TED-Hose. In and out. You don't typically bring STDs machines home, but I've had people try to take them in the hospital. Those suitcases they bring in, I don't know what they're thinking about. Moist dressings. If it's open, we tend to use moist dressings, okay? Nutritional therapy, we've gone through the good nutritional therapy. A routine antibiotic therapy. Drug therapy, so antibiotics, pain medication, anticoagulation, anything they need. And then what would be some alternative therapies that people are starting to use? They're getting really big, some of this stuff.
It'd be like yoga.
Yeah.
Stuff like that.
Reiki. I like Reiki's fun. What else?
What's the one with the needles?
Acupuncture? Yep.
Acupuncture.
What else?
Which?
They use a lot of cupping. but-
Cupping? If you haven't heard about cupping, it's very interesting.
They did that in the Olympics.
Yep.
Yeah, my
It's
brother.
not very common in Olympic
Does
people.
it make me go up a cup size?
Yeah.
Damn.
So, I'm just a little confused on what's the difference between a VTE and a DVT. Like,
Oh, VT and DVT?
yeah.
One is sincerely just more severe than the other. And they have a couple different variations, so especially when it's under the descriptions for